Hi, welcome back to my channel, and today I'm going to be talking about corneal cross-linking, what is needed to know. Definition. Corneal cross-linking is an FDA-approved minimally invasive intervention that utilizes UVA lights and riboflavin. The goal of cross-linking is the artificial increasing of the degree of crosslinks in the corneal stroma for sufficient mechanical stability. Mechanical stability is being identified from chemical composition, the structure, and organization of the extracellular matrix. History of cross-linking. In the early 80s, keratoconus was identified as a weak cornea from a biomechanical point of view. Edmund, Andreasen, and Nash performed biomechanical measurements, and they confirmed a lower Young's modulus and lower viscoelastic properties in this disease. It has been assumed that these results are related to the collagen and proteoglycans. In 2003, Wolenczak et al. Introduced CXL as a minimally invasive procedure to halt the progression of keratoconus. And in December 2005, the first commercially available cross-linking device and riboflavin were delivered by Peschke, and the first International Corneal Cross-Linking Congress took place in Principles of cross-linking. Cross-linking significantly increases corneal tensile strength and biomechanical resistance to collagenase digestion. CXL has multiple effects in the anterior cornea. Those are biomechanical stiffening, increased resistance to proteolysis, thermostability, reduced corneal permeability, anti-hydration effect, and anti-infectious effect. Biomechanical stiffening is happening under photodynamic effect in combination of UVA lights and riboflavin. Main components of photodynamic effect are photosensitizer, light, and oxygen. The role of oxygen in cross-linking. Oxygen is important to reduce biomechanical stiffening with cross-linking. The decreased irradiation time and epithelial on-treatment leads to a reduced available tissue oxygen concentration during cross-linking, and this decreases the therapeutic effect. Of course, the clinical impact will be also dependent on the stage and the progression of keratoconus. What should be also noted, thin corneas have higher oxygen availability, which might reduce the required amount of UV fluence in advanced keratoconic corneas. Riboflavin. Riboflavin is photoactivated chromophore that plays an integral role in facilitating cross-linking. There are two types of riboflavin: hypoosmolar formulation, which is being used to artificially thicken thin corneas prior to cross-linking, and hyperosmolar formulation, which is being used to reduce corneal edema when treating bullous keratopathy. Riboflavin has a buffer function, or another way to name it is riboflavin shielding against UVA. It absorbs UVA lights, thereby reducing the risk of damage to posteriorly located structures, such as endothelium, lens, and retina. What should be noted, during riboflavin UVA treatment, keratocyte apoptosis occurred up to depths ranging from 270 to 350 micron, and this is most of the time also the range of demarcation line after the treatment. And this damage of keratocytes appears to be transient, and repopulation of keratocytes with a normal keratocyte density within the entire corneal stroma is being observed at 6 months follow-up after the procedure. Mechanism of riboflavin action. So UVA lights affect riboflavin, and it brings to formation of activated riboflavin or singlet riboflavin. This promotes two pathways: oxidative pathway and glycosylation pathway. Oxidative pathway has two types: type 1 non-oxygen mediated and type 2 oxygen mediated. Non-oxygen mediated frees riboflavin radicals, those formates riboflavin triplets, and type 2 reaction leads to formation of singlet oxygen species. In a glycosylation pathway, it leads to advanced glycation end products mediated mechanism. The listed end products lead to formation of covalent crosslinks and resultant strengthening of cornea. CXL protocols were developed based on the principle to maximize treatment efficacy, safety, and comfort. Modifications have been made according to UVA radiation, riboflavin's route of administration, oxygen supplementation, and to improve visual acuity. So let's start with conventional CXL or Dresden Protocol. This is the epithelium of oxygen delivery from room air. UVA delivery is 3 mW square centimeters for 30 minutes. This short information will be added in every slide to each protocols accordingly. The first step for this protocol is the debridement of the epithelium, and at least 1 mm epithelium should stay intact around the edges to avoid damaging the limbal stem cells. Then, soakage with riboflavin, followed with the UVA radiation for 30 minutes. What should be noted that inclusion criteria for this protocol are corneas with a thickness at least 400 microns after deepitalization in order to prevent endothelial toxicity. CXL protocols based on UVA radiation. This is an accelerated protocol, and the main purpose of this protocol is to reduce the time of UVA radiation. But what is important in this protocol is always to achieve the dosage of the surface energy 5.4 based on Bunsen-Roscoe's law of photochemical reciprocity. CXL protocols based on improving riboflavin delivery. Riboflavin delivery TE protocol or Epi-on protocol. During Epi-on protocol, the procedure can be combined with using chemical enhancers such as benzalkonium chloride, gentamicin, chlorobutanol, and trometamol, as well as iontophoresis or femtosecond laser transepithelial phonophoresis. There are following challenges of this procedure. Those are that riboflavin does not penetrate the intact epithelium, and an intact epithelium diminishes oxygen diffusion, and demarcation line during this procedure is approximately 200 micron, which is not enough for an effective cross-linking process in the cornea. In this slide presented parameters for an effective TE cross-linking. Those parameters are based on the modification of epithelial permeability, which I listed already, then modification of riboflavin solutions, such as using without dextran riboflavin solution or hypoosmolar solution or higher riboflavin concentration. The next parameter is a modification of UVA dosage and modification of the application by increasing of contact time and wash away of riboflavin from the epithelium before the irradiation. Here is the publication of TE protocol. This is from Soeters et al. The author compared transepithelial versus epi-off corneal cross-linking for treatment of progressive keratoconus in a randomized control trial. And the author concluded that the study showed that although transepithelial cross-linking was a safe procedure without epithelial healing problems, 23% of cases showed a continued keratoconus progression after 1 year. And therefore, at this time, they did not recommend replacing epi-off cross-linking by transepithelial cross-linking for treatment of progressive keratoconus specifically. CXL protocols improving oxygen diffusion. Pulsed UVA. So in this slide, you can see one of the publications who described this protocol. This is from Gore et al. In this study, corneas with thickness less than 375 micron were excluded. High fluence pulsed UVA was delivered at 30 milliwatt energy for 4 minutes with a 1.5 seconds on and off cycle. At 6 and 12 months, modest corneal flattening with a keratometric stabilization in 98.3% of eyes was noted. No changes in central keratometry were noted, and moreover, mean corrected distance visual acuity, manifest refraction, and endothelial cell density did not change. Another study of pulsed UVA is from Mora Marco et al. Here, the author compared accelerated cross-linking using continuous UVA exposure at 30 mW for 4 minutes with accelerated cross-linking using pulsed UVA with 8 minutes, 1 second on and 1 second off of UVA exposure at 30 mW, and stromal demarcation line was significantly deeper in the pulsed UVA group compared to continuous group. Next, a protocol for improving oxygen diffusion is the protocol of enhanced fluence pulsed light iontophoresis cross-linking. Here's the study from Mazzotta et al. In this study, patients underwent iontophoresis-assisted cross-linking with riboflavin solution and received UVA radiation of 18 mW of pulsed light on-off exposure. At 3 years, the average uncorrected distance visual acuity improved from 0.50 to 0.36 logmar. Anterior segment optical coherence tomography showed that the demarcation lines were situated at an average depth of 285 in more than 80% of patients at 1 month postoperatively. Another study of periocular oxygen supplementation is from Seiler et al. And in this study from Seiler et al. Was concluded that supplementary oxygen increases the oxygen availability during corneal cross-linking, and at higher irradiances, supplementary oxygen is beneficial and it allows a potentially more efficient cross-linking. CXL Protocols optimizing visual acuity. Let's start with the customized protocol or CurV protocol. Here's the study from Mazzotta et al. In this study, a total of 27 eyes were included, and I will just tell you the title of the study. It was a customized corneal cross-linking for progressive keratoconus, and clinical and OCT outcomes using transepithelial approach with supplemental oxygen was evaluated. So, as I said, the total of 27 eyes were included in the study. Significant improvement in corrected distance visual acuity with flattening of steep keratometry at 6 months follow-up was observed. 2 demarcation lines were observed also at mean depths of 218 and 325 microns. Demarcation lines were approximately 30% deeper in this series than previously reported by studies which utilized epi-off CurV protocols. And these studies suggest that there is a possibility of conducting CurV protocol without the need for de-epithelialization. And here is another study of customized protocol from Theo Seiler et al. Here, the author showed 1-year results with greater changes in maximum keratometry values and also superior epithelial healing time than patients treated with an epithelial of protocol. Athens protocol. This is a topo-guided transepithelial PRK followed by CXL, and here is the study from Kimionis. The conclusion of the study is that simultaneous PRK followed by CXL seems to be a promising treatment capable of offering functional vision in patients with keratoconus. Next protocol for optimizing visual acuity is a Cretan protocol. This is a transepithelial PRK with cross-linking, and this is the study of Grenzelos et al. The author showed that a 3-year prospective comparative study of 30 eyes showed visual improvement and reduction in corneal astigmatism. Patients who underwent routine epithelium of CXL did not experience improvement in visual acuity or corneal astigmatism. ICRS with cross-linking. Here is the study from Singhal et al. The author compared accelerated cross-linking alone, accelerated cross-linking with ICRS, and accelerated cross-linking topo-guided PRK in progressive keratoconus and other corneal ectasias. As a conclusion of the study, CXL alone might be best for keratoconus patients who meet the inclusion criteria. CXL ICRS might be more effective for eyes with more irregular astigmatism and worse CDVA, and CXL topo-guided PRK is useful for eyes requiring improvements in irregular astigmatism but still have good CDVA. CXL Protocols anti-infective application. This is a photoactivated chromophore for infectious keratitis or CACXL. CACXL, in terms of bacterial keratitis, there are a few publications, such as a publication from Tafik et al., this is from 2020, who showed a higher proportion of patients in the group receiving combination treatment of antibiotics with CACXL experienced complete resolution of ulcers. Additionally, the mean resolution period was shorter compared to patients treated with antibiotics alone. Torres Neto et al. The same year also showed that CACXL alone is as efficient as antimicrobial therapy in small ulcers up to 4 mm in size. CXL protocols for thin corneas. CXL using hypoosmolar riboflavin. Hafezi et al. In 2009 published that corneal swelling occurs due to hydrophilic properties of stromal proteoglycans, which form collagen-free lakes and increases corneal thickness. Hypoosmolar riboflavin results in large individual variations in corneal swelling duration and range. So swelling duration ranged from 3 to 20 minutes and extent of swelling ranged from 36 to 105 microns. However, from the publication of Stojanovic et al. In 2020, the efficacy of hypoosmolar riboflavin has been suggested to be less pronounced compared with standard formulations. Contact lens assistant cross-linking. Jacob et al. In 2014 showed the protocol which involved placing an UVA barrier-free soft contact lens soaked in isoosmolar riboflavin 0.1% for 30 minutes on the cornea. Once the corneal thickness was confirmed to be greater than 400 microns, UVA irradiation was combined with administration of isoosmolar riboflavin 0.1%. Their study found that CACXL achieved a stromal demarcation line with mean depths of 252 microns with no significant endothelial loss secondary to UVA toxicity. However, Klink et al. In 2017 and Wolenczak et al. In 2019 published that the presence of a contact lens over the epithelium creates an artificial barrier that reduces oxygen diffusion into the stroma, which reduces efficacy of riboflavin and UVA in inducing cross-linking. Decision-making for CACXL and accelerated cross-linking. Here is the scheme from Srivatsa et al. And this scheme is based on measured pachymetry. In case if the pachymetry is more than 400 microns, then conventional cross-linking or accelerated cross-linking was performed. In case if the pachymetry was less than 400 microns, then contact lens and cornea were soaked in 0.1% riboflavin for 30 minutes. Then remeasurement of the corneal thickness was again performed after 30 minutes. After pachymetry remeasuring over contact lens, if the pachymetry was more than 400 microns, then CACXL or accelerated CXL was performed. In case if the pachymetry over contact lens was less than 400 microns, then 2 drops of distilled water was added to minimally swell the cornea, and pachymetry was remeasured again. And when it was confirmed that the thickness is more than 400 microns, CACXL or accelerated CXL was performed. Epithelial island CXL technique. What is epithelial island CXL? This is the epithelial debridement over areas of a thicker cornea, undebrided epithelium or island over the thinner apical area. And once riboflavin is applied, the island protected the thin cornea from UVA. And here is the publication from Kagel et al., who showed the outcomes of corneal collagen cross-linking using a customized epithelial debridement technique in keratoconic eyes with thin corneas. The study observed an improvement in uncorrected visual acuity, best corrected visual acuity, flattest cheirometry value, and steepest cheirometry value 1 year postoperatively. However, there was significant endothelial cell density loss 1 year post-op. Epi-off lenticule on CXL. What is epi-off lenticule on CXL? So riboflavin was applied on a donor corneal lenticular instead of being applied directly into the debrided corneal epithelium. This donor corneal lenticule was taken from a patient who previously underwent smile refractive surgery. Here is the outcomes from the publication of Cagini et al. In 2020, who showed that visual acuity and endothelial cell density remained stable over a 12-month follow-up duration, and demarcation line was seen in all patients by 6 months of follow-up. And the last protocol from CXL Protocols of seen corneas. This is a sub 400 protocol. UVA delivery in this protocol was adjusted according to the corneal thickness in order to achieve a safe depth of CXL 70 micron away from the endothelium. Here is the outcomes from the publication of Hafezi et al. In 2021, who showed that a significant improvement in corneal maximum keratometry values and no change in corrected distance visual acuity. CXL protocols for pediatric cornea. Here I will be very specific because what is known already that keratoconus in pediatric population is often more aggressive than in older age groups. Epi of CXL seems to be efficient for the first 2 years after CXL, but there is a controversy about the longevity of the effect. TECXL, although less efficient, may be considered in some selected cases. Why may CXL not work in some patients? It's because of genetic influence, the biomechanical behaviors may be altered, atopy, allergy, and further progression of keratoconus. Other indications for CXL, those are combined with LASIK surgery or smile refractive surgery, and the name is the LASIK extra or smile extra, and also hypoosmolar riboflavin. So in the first case, there are variable short-term results reported, so longer-term and larger-scale studies required. In terms of hypoosmolar riboflavin protocol, the reduction of central corneal thickness and visual acuity was observed in patients with bullous keratopathy. Contraindications for cross-linking. Those are pregnancy, breastfeeding patient, prior herpetic eye infection, active ocular inflammation, severe central or paracentral scars, autoimmune disorders, history of poor endothelial wound healing, and corneal thickness less than 400 micron is still a relative contraindication. Complications after cross-linking. The most common complication after cross-linking is transient corneal haze and persistent corneal haze. Transient corneal haze is a secondary condition due to increased collagen fiber diameter post-CXL, and this is not associated with visual disturbances and often regresses after 12 months. Persistent corneal haze lasts beyond 12 months, negatively impacts visual acuity, and thought to be secondary to the ongoing keratoectasia and corneal remodeling. Risk factors for persistent corneal haze are pre-op, this is the keratoconus with minimal corneal thickness less than 400 micron, presence of preoperative activated keratocytes in the arterial stroma, which can be defined through confocal microscopy. Intraoperative risk factors, those are the focus of UVA source, lack of riboflavin 0.1% during irradiation, excessive riboflavin dextran 20% solution, which leads to dehydration. And postoperative risk factor is a non-compliance with topical corticosteroid therapy, infective keratitis, therapeutic lens intolerance, and presence of Langerhans cells after contact lens removal. Other complications for CXL, those are sterile infiltrate, infectious keratitis, persistent epithelial defect, stromal scarring, corneal melt, corneal endothelial decompensation, damage to the lens or retina, and late onset of peripheral keratitis. Here are a few clinical samples from complications after CXL. Here we can see a sterile infiltrate 1 day after CXL. Here's a stromal scar after CXL. And in this picture we can see a non-healing epithelial defect, and this defect likely related to bandage contact lens rubbing against the steep portion of the cornea. And in this case epithelial healing can be facilitated by contact lens removal. Future of CXL. In terms of dose response, it's important to understand the relationship between UV A, riboflavin, and oxygen. In terms of diagnostic tools, clear understanding of corneal epithelial mapping, developing machine learning algorithms which identify subclinical keratoconus, more research on genes and predisposing factors, standardized guidelines and protocols for treatment are required. Alternative agents such as rose bengal can be also used in order to provoke cross-linking in the cornea. So light-activated rose bengal can be used to seal wounds in cornea. Corneal cross-linking was evaluated by rose bengal under green light, and this is RGX, and RGX-initiated cross-linking did not decrease keratocyte viability. So more studies with this kind of alternative agents are still required. That was all for now. If you're not subscribed, please subscribe to my channel, and you can also follow me on Instagram for new updates. Thank you for watching. Stay positive, stay healthy. Bye.